Today we're going to talk about the segmental endoscopic brow lift. Brow lift surgery can be done several different ways. The approach that I advocate is called an endoscopic brow lift. The segmental approach is something I dreamed up over 15 years ago, and now we call it the segmental endoscopic brow lift. So when I was a young man going through my training, I was taught several different approaches to how to lift brows, and the main approach back then was to make a big incision across the head. It's called a coronal lift or a trichophilic incision, assuming you have hair. That means hair kind of right at the border of the hairline. That's the advantage of that, is you don't lift the hairline. Disadvantage, obviously, the scar's more evident, or can be. The disadvantage of both those approaches is that they cut right through the structures that actually hold your brow in place. I mean, in general, the frontalis muscle, which is the only muscle that lifts the brow. So just by making those big incisions, you're actually weakening the brow, and in the long run, not allowing it to stay where you want it to be. The other disadvantages of that approach is that it cuts through the nerves that provide sensory touch and itch to your head. So almost all those patients end up with spots, areas that are what we call cause paresthesias, or funny, the nerves don't quite act right. So that's another major disadvantage. And thirdly, when you do brow lift surgery, you have to be able to control the angle of the lift. So that's something I teach at our academy. I've been doing my talk on endoscopic brow lift and now the segmental endoscopic brow lift for probably 20 some years. So what I mean by that is, when you lift a female brow, you want the angle of the lift to be at about 30 to 45 degrees, which is like this, because you want that pretty arch. And notice the angle is in this direction and not straight up. If you lift the brow straight up, you cause the patient to look operated on or surprised. So for females, you want to go laterally and superiorly about 30 to 40 degrees. For males, you want to go 0 to 10 degrees in what we call a T-shaped brow. So the angle of attack is different. The angle of the rejuvenation is different depending on the sex of the patient, and you really can't do that as well with a coronal lift. You can do it much better with an endoscopic lift. So the advantage of the endoscopic lift is it maintains the frontalis muscle, which allows for a lot better longer-term results, especially if you do it subperiosteal, but I won't get into that. That is the approach I recommend to doctors. You don't have the permanent sensory problems, paresthesias. At least I haven't had that issue that I know of for like forever, or just ever since I've been doing it. And you can control the angle of your lift in a much more predictable way. Now, what do I mean by the segmental approach is that 15 years ago, even though I was at the forefront of doing endoscopic brow surgery, I was probably one of the first 5 to 10 guys in the country that started using the endoscope for brow surgery many years ago. I was doing brow lifts the same way on every patient, i.e., meaning when I got down here and I found structures that were holding the brow in place, I would just release them and then try to make the brow look good, which I was pretty good at, but it wasn't to my liking in terms of predictability. So what I dreamed up was trying to come up with different ways of doing a brow lift depending on each individual patient's physical exam. So by physical exam, I mean, where is the position of the brow in relation to the supraorbal ridge, this bony ridge? How thick is the patient's skin? How strong are their brow depressors? A couple other things, but those are the main things I look at. And so now, and for the past 15 years, I've been putting people in 5 different categories of aging, from obviously category 1 through 5, 1 being the least signs of aging in the brow, and 5 being the most. And depending on which category of aging I put patients in, that will determine the type of release I do of the structures that hold the brow in place. Those structures are all underneath the skin. You can't see them, and you can't tell that I've done the release afterwards. It's underneath the skin, and it's not something you can see. So by changing my release based on the categories of aging, I found that my patients have a much more predictable result. Predictable meaning that the end result is what we want for that particular patient based on their preoperative exam. I've shown that in a paper, which I'll read the title of it to you. I published it in 2021, so a couple years ago. It's there's the paper. You can find this in Facial Plastic Surgery. So the wording's pretty wordy. Preoperative classification system used to determine release performed during endoscopic brow lift. Ergo, I now call it the segmental endoscopic brow lift. It's much easier to remember. So that was my 15 years of experience in that paper of using that approach, and I did prove, I think, conclusively that following this approach, using different releases for different people's anatomy based on their degree of aging, results in a more predictable result. Patients are happier. I'm happier. And it's something that I've been teaching now at the American Academy of Facial Plastic and Reconstructive Surgery for probably about 6 to 8 years. And I would encourage you to find somebody that is familiar with that approach. I think it is better.